There's been no suggestion that the care that Brompton gives has not been good care.
There's never been a challenge around the activity level at the Brompton.
In no way are we suggesting that the care that the Brompton has given is not excellent.
Anyone would acknowledge that the research that's been undertaken at the Brompton has been excellent research. It's an important research centre.
Where the Brompton doesn't currently meet the standards is around paediatric co-location.
The services that we provide at the Brompton already meet the standards. We provide a single paediatric team across 2 hospitals between Chelsea and Westminster and the Brompton. And they work together on the paediatric intensive care unit, on the ward. They're members of a multidisciplinary team. If we need them to be there every day, they're there every day. If we need them to be there once a week, they're there once a week.
My son was under the Royal Brompton and he had multiple different specialities needing to attend his bed, and I never had any problems whatsoever in terms of the speed that those people from Chelsea and Westminster came to his bedside.
What's important is the quality of care the patient gets, and I think we can hand on heart say the quality of care our patients get is exemplary. Of our emergency cases, which is a rarity, but of our emergency cases, 100% of the time in the audited 12 months, we got someone there within the time period.
What happens at co-located hospitals that doesn't already and cannot happen at the Royal Brompton? Please, can you also point out to the evidence that this results in better care?
I'm not aware that there is any evidence that co-location improves patient outcome.
But there are many things in the provision of healthcare that are quite difficult to find robust clinical evidence for, and yet we make decisions about how services are delivered with less than perfect evidence in a number of different areas. We did ask the Sheffield team during the process of developing the standards to look for the evidence, and they found some, but they found some evidence to support the presence of co-location, but not perfect evidence. So I think this is undoubtedly a consensus. This is not based on scientific proven evidence.
So I think it's disingenuous to imply that 2 years of discussion about the current definition of co-location was actually the fact. Fact was that the clinical reference group, in putting the standard, recommending the standards to NHS England, defined co-location as response time within 30 minutes, and it was only at the very last minute that a very small group, on which I think you perhaps were party to, changed to absolute co-location on the same physical site. So it's not true that the vast majority of clinicians recommending the standards actually agreed that absolute co-location.
I was on the CRG committee, the standards committee rather, for 2 years. It was not consensus. The paediatric cardiologist did not want that standard. That has to be, you cannot maintain that lie.
Because you've said there's effectively no evidence about half an hour versus co-location of the gastro, the endocrine, etc. But there is evidence, and strong evidence, about transition and the fallout when the adolescent is sent to a different hospital. And there's no question, you cannot ignore the importance of transition seamlessly, where we work together with our adult colleagues, and transition in one centre is vital.
The fact that you feel that you're going from home to some extent is vital in the healing process. And surely patients are the best judge of how important that is.
You make a very important point. Continuity of care and adult congenital heart disease care is hugely important.
1% of our children in paediatric intensive care need an emergency out of hours non-cardiac service, 1%. 90% of our children need that seamless transition to adult care. How that can possibly be weighed in the balance and found to be not important, I don't understand.
I've got 2 children with respiratory disease at the Brompton who are now adults. They've been there for 16 years. If CHD is removed from the Brompton, what provisions have you been made to ensure that the specialist respiratory care at the Brompton is not compromised?
We haven't at this stage done the detailed assessment about what the provision of any other services apart from CHD would look like, but we have acknowledged that that's one of the pieces of work we would need to do before we were able to start implementing overall.
We've got preliminary data so far, which we'll continue to collate.
I also went through Safe and Sustainable. One of the outcomes of that panel's decision was that no further decisions should be made on congenital heart disease services without looking at the knock-on impact to things such as intensive care, grown-up congenital heart, paediatric respiratory services. Now you're sitting here saying that this is something you're going to get around to looking at.
The issues to do with the impact of the potential, were these proposals to be implemented, and despite this scepticism, they are still for consultation.
How do I reassure my patients? What shall I tell them? Because at the moment I have no confidence at all that the respiratory angle and what's going to happen to the largest unit in the country, where are we going to go?
At this stage, we can't give the detail because we can't preempt what will come out of that consultation.
The reason the adult cardiologists work at the Brompton and the adult congenital unit is it's the best unit. I personally think it's probably the best unit in the world. They've all come from other countries, from other places, to be there. To then say that that calibre of staff would be happy to work in a level 2 centre with no surgery, no intervention, is complete nonsense.
In the last 8 months, just on the paediatric cardiorespiratory intensive care unit, we've had 6 patients referred to us from other places in the country which have not been able to have the care offered anywhere else in the country and have been told that they would die, and we have saved their lives.
This is an issue for the adult patients as well, so I can think in the last 2 or 3 months we had a patient who was a high-risk congenital patient with pulmonary hypertension who was pregnant, who was referred to us from Barts to have her high-risk obstetric care and her delivery in the Brompton Hospital because there was no other unit in London or probably most of the south of England who would be willing to look after that patient. And that combination of facilities and people will not happen in this new reconfiguration.
I'm very proud and grateful to have benefited from pioneering work and research done at the Brompton Hospital, as without it I may not be around today. Research is crucial in improving care standard, yet the plan will dismantle the world's leading adult CHD team.
To then say that you're going to completely fragment that whole team and that organisation with no structured plan about how you're going to do it and think that individuals moving to different hospitals are going to be able to replicate that research is ridiculous. And people have said this potentially will set back adult congenital research in this country by 10 years.
As far as I'm aware, the decision to close paediatric cardiology and cardiac services at the Royal Brompton was not made recently. If you look at the records of NHS England, you'll find that discussions were going on about this 4, 5, 6 years ago, even more. And what has happened is the discussion on standards has been fixed in a way to actually be compatible with the decision which had already been made.
The timescales in my world, because I work in construction, imply that you were looking at this again 5 years ago in order to achieve the delivery date of 19. So what you're talking about is preset.
I'm Bob Bell, I'm the Chief Executive of the Brompton. NHS England on July the 7th did come out in a press release published in the media to say that they are minded to decommission the service and have not retracted back from that statement. If the issue is that we need to come up with a better way of delivering services across the country and none of the centres comply with the standards, then surely the approach should be about what is it that can be done to correct these standards rather than close a place to boost up another and disrupt a whole bunch of people, families, children and parents, let alone teams that have been built over decades. There's something irrational in what you are doing.
Are you honestly telling this room of people that the whole point of this exercise The reason you're terrifying all these parents and destabilising all these clinicians is because there's no conjoined services, and for which you say there's no robust evidence that that improves anything. Is that really it?
I'm going to ask everybody in this room to put their hand up if they have absolutely no confidence in the process that is being undertaken. The vast majority of people in this room have no confidence in what you're doing. I just want you to go away with that feeling tonight. Thank you.